So thank you very much for this opportunity. So I have the great pleasure of working with all of you throughout the afternoon and the post-lunch time frame. So if I start to see a lot of head jerking, we may stop and do a stretch or whatnot, but we do have some activities that will keep you engaged, so hopefully we'll find value in this presentation, and hopefully we'll answer some questions. We'll keep you involved. We will have a break around 3 o'clock, and then we'll finish up the day. Then there will be a Q&A based off of the questions that have come in and have already been answered. We'll pull the team back together. So the idea is, as you put questions in, everyone's monitoring them live, and we're trying to get answers to them. So continue to submit your questions either via your cards or on the electronic format. And again, if you could, one question per card or one question via the submission. All right. So as we head in today, we're going to be talking about the percent of residents or patients with pressure ulcers that are new or worsened. And what you're going to find with a lot of the measures, we're doing a lot of cross-setting training. So we're doing training in the long-term care hospitals, inpatient rehab facilities, home health, and skilled nursing. And some of these measures have been pulled from other areas, so you'll see this term like resident. So in home health, they're either probably a patient or a client for you. So just know that some of the terms that are in here are related to where if the measure was already being used in another setting, it's being pulled from that setting. So let's talk about what our objectives are for today. So hopefully by the time we complete the training at the end of today, we'll be able to define the following terminology. And we actually have an activity around this, and that is around the QM numerator, denominator, the denominator exclusions, the measure time windows, the QM calculation algorithms, the risk adjustments, and how all of this impacts it. And this is important because so often when we've worked with organizations, they'll say, well, I don't understand why my quality measure is this way. And so we're going to give you some tricks of the trade on where to find this information. By the time you leave today, you'll be able to go back to your agencies and be able to train your staff and have your nurses, your therapists, and everyone understand the impact of what they're answering on the OASIS to these quality measures. So we hopefully will be able to demonstrate a working knowledge of two items, M1311 and M1313. And we're going to look at the intent of those. We're going to interpret the responses. We're going to apply instructions in order to accurately respond to practice scenarios. So we've put in a lot of practice scenarios in here, one to keep you engaged, to think it through. All of these materials will be posted with the answers so that you can use them, hopefully in training of your own staff or taking the opportunity when you're educating your staff. And or you'll see similar type of scenarios, and you may want to take an actual patient of your own and say, let me build a similar scenario but with a client that we had. And then discuss how to resolve the common stumbling blocks that are encountered when we're encoding these. So as we go through, you'll see in many of these presentations, we present a acronyms list, and so the acronyms are here. And I'll try to tell you about each acronym as I come upon it, but it is listed here. So before we really start in my presentation, I'm going to be using a word called code or coding. And what I wanted to make sure, when you hear in this presentation around code or coding, and actually in tomorrow's presentations, we're using it as the idea of responding or scoring the OASIS and the assessment item. And it's not to be confused with the coder. So that may be a person who's trained in ICD-10 who is actually going in and putting a medical diagnosis. And believe it or not, even when we've trained on this in the past and we've done this introduction slide, we'll get at least 4, 5, 6 questions saying, what do you mean, the coder has to do the OASIS now? No. So you may get sick of hearing us say this, but we're trying to reinforce just the words that we're using here. We're talking about coding or encoding, meaning responding to the questions in the OASIS. Does everyone understand that? Yes? Okay, good. So no one here is going to ask that question, right? About what a coder is? Okay, good. All right. Okay, so let's jump right into our presentation today. So we're going to talk about the percent of residents or patients with pressure ulcers that are new and worsening. And this QM has been finalized as a cross-setting quality measure, so hence why we're talking about this today, to meet the requirements of the IMPACT Act, addressing the domain of skin integrity and change in skin integrity. So these are similar questions that are being asked in all of those settings that I talked about, the long-term care hospital, inpatient rehab facility, skilled nursing, and OASIS. Some version of this is being asked. And so the quality measure is intended to encourage home health agencies to prevent pressure ulcer development or worsening and to closely monitor and appropriately treat existing pressure ulcers. I hope that you were doing that anyway. I would trust that you're all doing that, but this is the first time where we might be able to start to understand using similar measures in the various settings about pressure ulcers, when they present in a care time frame, if a patient or a client comes in with a pressure ulcer, does it heal, does it get worse, and what time frame? So you get to understand, having these data really allow us to then take an opportunity to do a deeper dive and to understand the complexity of wound care. So the quality measure description, well, it reports the percent of quality episodes in which the patient has one or more stage 2 to 4 pressure ulcers present at discharge that are, and I underlined in my notes, new or worsened since the beginning of the quality episode. So that's an important definition. And the quality episodes are defined as pairing a start, a SOC, or a ROC, so start of care or resumption of care, with an end of care assessment. So we won't be looking at this measure until we have a quality episode, right? A beginning and an end of it. And the measure is calculating using data from the OASIS. So what I'd like to do is we're actually going to do a scavenger hunt. So it's not literally like a scavenger hunt when you're a kid where you're going to actually go find things around the hotel. We're going to stay in this room, but we are going to do a scavenger hunt. And in preparation for our scavenger hunt, we need a few things. On your tables should be in the center, so if you go pull it, I think there's a couple of copies of the Home Health Quality Reporting Program specifications for cross-setting quality measures, calendar year 2016, final home health PPS rule. So it's in the center, it's a thin little packet, it's in the center of your table, and I think there's 2 or 3 on each table. So if you can pull that, so this is a collaborative scavenger hunt, so not everyone gets one. Within the slide deck, I will tell you for when you get back to your organizations, we have a link in there where you can grab it. The other thing I need you to do is go into your folders. On the left-hand side of your folders, I think it's if these are put exactly the same, I've been moving stuff around in my folders, but I think it's like the 3rd packet back. There is a set of slides that looks like this, and it says scavenger hunt on it. Everyone have that? Okay, if you can pull that out. Oops, sorry. For this activity, you're going to need what I call the technical specifications, okay, that document, and this slide deck that you're going to actually fill in the blank. Now, while you're in your folders, if you could do me a favor, towards the back of your folder, I think it's second to last document in there on that right-hand side. You're not going to use this immediately, but just pull it out so you have it available to you. Will be the Home Health Quality Reporting Program, M1311 and M1313 practice scenario sheets. So just if you could pull this out and leave it to the side, once we get through the scavenger hunt and I go through all of that, we're actually going to go through a whole bunch of scenarios and whatnot. And throughout the rest of the afternoon, we're going to be using this coding sheet so that as I present a case, you're actually going to encode or code this, and then we're going to review the answers. Everyone have those? Okay. So let me get back to my documents here. All right. So what we're going to do, so we have, with this activity, we're going to take about 10 minutes to do this. Work at your tables, either in pairs or threes. It depends on how many people are at your table. And what we would like you to do is take your scavenger hunt form and your technical specification guideline, and I want you to read through the slides, and there's some blanks. There's actually 8 blanks. And I want you, as you read through, find the answer for these. So the first one is on the second slide here, and it's asking around the numerator, and there's a fill in the blank. And what it does is you'll go through this technical specification, and you're going to find the definition of what is a numerator or what is the denominator. So you're going to go through this and fill in the blanks. It will take you probably 8 to 10 minutes to do it. The reason that we're actually having you do this is a good thing to bring back to your organization and have people understand what's feeding my numerator, what's feeding my denominator, what are some of my exclusions. If I wanted to do the math and do some of the calculations, how would I calculate my own measures? There's a lot of people who like to do that quality check themselves. So this gives you the opportunity to have that data and those resources. So we will start now, and we'll start back around 5 of, unless everyone seems done sooner, and then we'll start sooner. So work together collaboratively at your table. I'll walk around if you have any questions, and we have some other staff who can do the same, and we will regroup shortly. Okay, so how did that feel? Okay to go through that technical specs? Did that help? Who has seen those technical specifications before? 1 person, 2 people. It's hard to see with some of the lights. Okay, great. Those technical specifications, or these documents who give you all this detail, are important. So as we move forward and there are additional measures and things that are coming out, there will always be this kind of associated document that will tell you about what is the numerator, denominator, exclusion criteria, and whatnot. So now that you've had an opportunity to look at one, in the future, it will probably be set up similarly, so at least you've had some experience in looking at it. But let's go through your scavenger hunt. So we have the percent of residents or patients, and we're looking at the numerator. The number of blank quality episodes for a patient whose assessment at the end of the care indicates 1 or more new or worsened stage 2 to 4 pressure ulcers compared to the start and resumption of the care assessment. Do we have any guesses? Completed, exactly. And then, so we're looking at the denominator, and the denominator are the number of quality episodes, except those that meet the exclusion criteria, and we're going to talk a little bit about those in the home health quality episode as defined by pairing the assessments with the start or resumption of care and the end of care. All right, so we have the completed. So then we have the new or worsened pressure ulcers are determined based on examination of all assessments in a patient quality episode for the reports of stage 2 to 4 pressure ulcers that were not present or at a lesser stage on the SOC or the ROC, as evidenced by, and what you'll see there when you see here is stage 2 at M1313A, it's saying it's greater than 0, or in each one of those for stage 3, stage 2, 3, or 4. And so it's a comparison. It's saying, when I did my SOC or my ROC, do I have any ulcers that are new at stage 2 to 4, or worsened, meaning they were at a 2 and now there were 3, or there were 3 and now there are 4. Okay, that's what this is looking for. So let's look at some of the exclusion. The exclusion criteria is important in all of these. So an episode that ends in a blank are excluded from this measure. Well, we gave you the answer right in the definition, right? Correct. A death at home are excluded from this measure, as death at home assessment does not contain the items needed to complete this measure. So it makes sense. If you really understand with each one of your item sets, what questions are asked, you would then realize, well, they're not asking this M1313 question, so in fact it is an exclusion. And then we look at So let's see, we have here M1313, which is collected only at discharge, therefore episodes ending in a transfer or inpatient facility or death at home are not considered for this particular measure, and it's just because you're not asking that question. And then we have episodes without an assessment completed at the start or the resumption of care, and an assessment completed at the end of care are excluded, and then episodes are excluded if the discharge assessment does not have usable responses in M13A, B, or C. So now that actually has come up as a question in the past. So what are valid responses? And the valid response include the numbers 0 to 9, blanks due to skip patterns. So if you were doing this on a computer system, it would kind of gray you out and just take you to the next question, or dashes. And these are all considered valid item responses and not considered missing data. But please note that a dash should not substitute for a 0. All right? But so all of those people are asking, what is a valid response? All right, so let's look at the measure time window. So calculated blank using a rolling 12 months of data. What do you think? Right, it's calculated quarterly. And all completed quarterly episodes, except for those that meet the exclusion criteria during the 12 months, will be included in the denominator and are eligible for inclusion in the numerator. And for patients with multiple episodes during the 12-month time frame, each episode is eligible for inclusion in the measure. So if they have multiple quality episodes, each one can be included if it meets the criteria. So that's an important caveat for that one. The measure will be risk adjusted based on the evaluation of potential risk factors for their statistically significant impact on the outcomes. And tomorrow you're going to learn about a lot of the covariates related to that. And patients with characteristics or conditions that put them at increased risk for skin breakdown or impact their ability to heal are treated differently in the measure calculations. So if someone is relatively in good nutrition, they're up and about, they're continent, they have reasonable mobility to be able to weight shift and whatnot, would be very different from someone who had poor nutrition, who was immobile. Think about it that way, right? Just logically makes sense. That person would be more dependent and certainly higher risk. And the risk adjustment is used to account for the medical and functional complexity of our patients. So let's look at some of the risk adjustment factors. Indicators of supervision, touch, assistance, or more at the sock or the rock for functional mobility item, and then fill in the blank. Lying to sitting, I hear, okay. I'm gonna go through the rest of these and then we're gonna look at the answers. Indicator of bowel incontinence, at least occasionally at the initial assessment, all right. Diabetes mellitus, blank, or peripheral arterial disease, okay. And then indicators of low body mass index based on height and weight on the sock rock. So let's look at these. So yes, you are correct, lying to sitting on the side of the bed. And then we have diabetes mellitus, peripheral vascular disease, or peripheral artery disease. And that would be coded at M1311. And again, we're going to go into more detail on coding of these and all of the criteria around it tomorrow. And then, of course, we have the low body mass index. So notice it doesn't have anything about a high BMI. It's just low BMI for this particular measure. All right, so now if you wanted to go ahead and calculate and understand the calculations behind the algorithms, there's a variety of steps that you would need to do. And step one is calculate the denominator count, and that would be calculate the total number of quality episodes with a selected target OASIS assessment in the measurement time window that do not meet the exclusion criteria, meaning they can be included, right? So these are the group that can be included. And then step two is calculate the total number of episodes in the denominator. So now we have the total kind of sample, that's my denominator, whose OASIS assessment indicates one or more new or worsened pressure ulcers at discharge as compared to the start of care or resumption of care. So now I had my total population here that could fit into it. Now my numerator is a subset of those, right? And those are people with new or worsened pressure ulcers as meeting the definition. So that's step 2. Then we want to calculate the agency blank. Okay, great, the observed rate. And you divide the agency numerator count by the denominator count. Now that's fairly simple math. Most of us can do that, and that would actually give your observed rate. And it tells you to do exactly that, divide result of step 2 by step 1. All right, so now let's look at calculate the predicted rate for each quality episode. We need to do, this is step number 4, determine the presence or absence of the pressure ulcer blank for each patient. Right, and those are the risk factors. And why are they important? We're going to learn more about it tomorrow, but those, remember when they talked about some of the weighting of it? So certain patients are at a higher risk versus lower risk of developing new or worsening pressure ulcers. Then step 5 is use the patient level covariance in a logistic regression model. How many people know how to do a logistic regression model? 1. Will you be leaving your card for everyone? Yeah, okay. So the nice thing is this is done for you. This is getting into some complex math. So you just know that there is a mathematical process that happens to calculate this. And it's the probability that a patient will experience an ulcer given the presence or absence of risk characteristics measured by the covariance. So that's that risk piece of it. What it's trying to do is make all of your patients or clients kind of on an even playing field. So you're comparing apples to apples versus apples to oranges. So that's the idea behind this measure of looking at that. And it's saying, if I have an agency full of walking, talking, healthy people, probably they don't need home care, right? But let's say you did, as compared to another agency who was caring for very disabled, maybe with, weight loss and all kinds of other things going on with them, that you'd say, well, wait a minute, my agency is not the same as your agency, or my client group is not the same as yours. So what they try to do in the math here in the covariance is try to make a level playing field. And that's really what you need to take away from that. And then step 6 is once a predicted QM rate has been calculated for all the quality episodes, calculate the mean agency level blank QM rate by averaging all episode levels predicted values for the agency. What's that word? Right, predicted. All right. I see all of it. Now, how many people are going to run and do this in their agency? Good. Okay. But it is important to understand it, even if you're not going to do the math. It's important to understand it. And then calculate the national predicted rate. Once a predicted QM value has been calculated for all the episodes, calculate the mean national level predicted QM rate by averaging all episode levels predicted values. And note that the same sample will only include those quality episodes with non-missing data for the component covariance. So with a lot of these, if you're missing data around, let's say, height and weight and a variety of other things, they need that data to then calculate these. So if that data is missing, they won't be able to appropriately calculate these. So I know most people have systems and processes where you're not submitting OASIS with blanks in it, where there should be data. And if you don't have the data, there's a process of using the dash, right? So there's something to put in there, unless it's a natural area where you can leave it blank, where it's only select those that are applicable, then that could be appropriate to leave a blank. But you need to know question by question and whether it feeds into these. So you'll always hear that caveat, if there's missing data, we can't use that person or that episode. And then calculate the agency risk adjusted rate. And to do this, you're going to calculate the agency level risk adjustment rate based on the agency level observed QM, which is step 3, the agency level average predicted QM rate, which is step 6, and then the national average predicted QM rate using the following formula. So you would take the agency risk adjusted rate, and that equals your agency observed rate plus your national predicted rate minus the agency predicted rate. And like I said, the nice thing is this is done for you. But I think why is this important? We just wanted to expose everyone to the idea that there is a methodology behind doing these quality measures, and it's important, at least at the agency level, that you understand what's driving this. And I'm going to go through certain questions, and I'm going to reiterate where it's really important and where an agency could get hung up in an area where you might be reporting poorer outcomes when in fact it's poor data going in. But if you didn't know which items drive this, you wouldn't know where to go looking. So that's part of what we're doing today. And what you will have, and these are available online, is these are live links, so you can actually go out, and any updates regarding to the quality measures will be listed here. You can click on them and then pull them down. But now you know that there are these specifications. You can pull them off. You can look at them, and you'll have at least an exposure and a slight understanding about how these are done and what data items are driving it. All right, deep breath. That was boring. But I appreciate how interactive everyone was at your tables and looking at your, and taking the technical specifications and going through them and engaging in this, and you did a great job, so I thank you for that. All right, so now we're going to head into the bulk of the rest of my presentation, and we're going to go through M1311 and M1313. Now, although M1311 is not included in the pressure ulcer QM, you're saying, well, then why the heck are you even talking about it, Ann? Well, it's important to understand the accuracy code of this item to inform M1313. So M1311, right, is what happens at the start of care and resumption of care, so it's here. And then we're comparing it, and we're looking at M1313. If you don't have accurate information at 1311, do you think you're going to have accurate information at 1313? No. Okay. Garbage in, garbage out. Okay. So that's the reason we're taking the opportunity, and we are making sure that you understand around 1311. And what I'm hoping to be able to do as we go through this session is to give you maybe some tips and some opportunities to go back and say, in your organization, in your agency, are you 100% confident, 90% confident, or God only knows, on how well your staff are coding a particular item? And then we can maybe talk through some strategies. The other thing I didn't mention, which is in your folders, not that you need to pull it out right now, but at the end of this session, maybe pull it out at the break, and definitely at the end of each one of tomorrow's sessions, is an action plan. And what we did is develop this action plan so that as you come up with an idea of, oh, that was a good idea, or I heard something that someone else was talking about at their agency, that would be a good strategy to ensure that we have staff kind of like a competency. I'm going to go ahead and write that down here, and then what are my steps? What am I thinking of today? So the idea is when you leave this training that you've got a little bit of a roadmap for yourself on some of the key things that you want to make sure that you either investigate, maybe you put some education in place, or you do some competencies around so that you're comfortable that your staff is encoding the OASIS accurately so that you have accurate quality measures. So that's called the action plan. All right. So the intent of this is to document the number, stage, and status of pressure ulcers. And we all know pressure ulcers are localized injuries to the skin and or underlying tissue, usually over a bony prominence as a result of pressure or pressure in combination with shear and or friction. So actually, I should probably ask this. How many people here are nurses? How many therapists do we have? We have a few. Social workers? Administrators? Clinical supervisors? I guess those would be nurses. Anything else? Owners, I guess? I don't know. Okay, others. So some of this clinical stuff you might get bored with if you're not a clinician, but well, hopefully I'll keep it to a minimum and you'll be able to understand what we're talking about. At very least, you'll know what's important when you go back to your agency. All right, so let's talk about some of the overarching principles. So the staging definitions are adapted from the 2007 National Pressure Ulcer Advisory Panel's Clinical Practice Guidelines. So let me stop right there. What year is it now? Okay. Okay, and they have new guidelines. It's 2017, very good. We should probably ask the date. I don't know what day of the week. I don't know, I've been traveling a lot lately. I could barely tell you, I think it's Wednesday. Okay, so, but these are based on the 2007 definitions. They were adapted. And I know that there's been some changes in the National Pressure Ulcer Advisory Panel guidelines. The idea of is it, pressure ulcer, pressure injury, a variety of different things. But please note that this has been tested and done. It's hard to change on a dime every single time the National Pressure Ulcer Advisory Panel changes. When you think about the magnitude of forms being changed, educating staff, QM calculate, it's like, in one hand, when this first came out, I'm like, well, what's the big deal? So a lot of you sitting in the audience saying, what's the big deal? Well, think about it as tossing a pebble into a pond and this ripple effect. It really does, when you start thinking about all of the things that it impacts, it takes time. So I can't tell you when or if ever these will be updated. I'm assuming at some point that they will be. But that does not preclude an organization from following current guidelines for assessment, using acceptable clinical practice guidelines, for what you're recording in your clinical documentation, and whatever your treatment protocols are. But for the OASIS, it's important to know the definitions, and it's important to follow the guidelines for completing the OASIS. And then we also need to identify and evaluate risk and determine the etiology of all skin ulcers, wounds, and lesions to ensure appropriate treatment. Now that's just one little dot in a whole bunch of slides that I'm going to present. But it's really important. It's been very interesting, some of the questions that have come out over the trainings that we've done in the various different healthcare settings. There are disease processes that can cause skin blisters. When you think about the complexity of peripheral vascular disease, what's a peripheral vascular ulcer, an arterial ulcer versus a diabetic ulcer versus a pressure ulcer. So it's not as simple as we think, but it's really important to understand that because what we're trying to capture here are pressure ulcers. All right, so it's very important that your staff understand the differences and are assessing the wounds so that they're not calling a peripheral vascular ulcer, if there's no pressure related to it, a pressure ulcer. But there's some people who think just because I see a fluid-filled blister that we should say, oh, that's a stage 2. No, these staging guidelines are related to pressure ulcers. All right, so that's an important piece, and it's amazing how many staff members, especially at the providing nurse level, at the home care level, are saying, oh, well, I heard this piece, so it's a fluid-filled blister, it's a stage 2. But they missed kind of the whole, there needs to be pressure involved, you need to do a whole assessment and determine, is it a pressure ulcer? So let's look at 1311, the current number of unhealed pressure ulcers. And you have now your practice scenarios. Let's go ahead and grab those, just keep them current, because we'll go through some opportunities for you to practice and code. They will be coming in a few minutes, a little bit. So let's look at the C2 revisions. So the following items have been revised in the OASIS-C2 effective January 1st, 2017. So they've been in place for a few months. And the C1 item was coded at M1308, and now the number is M1311. And so you'll notice that the definition the item tag has changed a little bit. We're missing the word unstageable, and it's saying the current number of unhealed pressure ulcers at each stage. Now, what you'll see here, I know this is small, you don't need to read it. What I wanted to show you is what the item looks like. in the OASIS-C1. And here's what the item looks like in the OASIS-C2. And you'll note the number changing in the formatting. And then the second row is new, and I know it's very hard to see here, but you will see some of that coding in your practice scenarios. So M1311, it identifies the number of stage 2 or higher pressure ulcers at each, oh, there's a fly here, at each stage present at the time of the assessment. And stage 1 pressure ulcers and pressure ulcers that have healed are not reported at this item. So this is that stage 2, 3, or 4s. Now, should we ignore a stage 1? What do you think? No, it's a great opportunity, right? The skin hasn't broken, but it's a non-blanchable red area. So we probably want to say what's going on with this particular resin, what can we do to help relieve pressure. So just because you're not encoding it on the OASIS doesn't mean you should ignore it. Okay, so we have, what are the time points that we're going to complete this item? Start of care, resumption of care, follow-up, and discharge from agency, not an inpatient facility. So the start of care, the assessment should be completed within 5 days. The assessment for resumption of care should be completed within 48 hours of return home after an inpatient facility discharge. And then the others should be completed within 2 calendar days of discharge. I'm not telling you anything that you don't already know, but just reinforcing that. So let's talk about M1311 and the specific instructions. So the terminology referring to healed versus unhealed in the ulcers refers to whether the ulcer is closed versus opened. So any of you who have done a lot of wound care, is anyone wound care certified here? Yeah, okay. Very good, so it's a couple of people. So there'd be people who argue with me, how do you know it's healed, Ann? Because what do we, you have to heal from the bottom of the wound up, right? But what we're talking here is whether we have epithelialization and whether it's closed. That's for this definition, that's where we're saying it's healed versus unhealed. So it's either open or it's closed. So a stage 1 pressure ulcer and suspected deep tissue injuries, although closed, meaning intact, would not be considered healed. So a stage 1 pressure ulcer is, if you remember correctly, non-blanchable, okay, red non-blanchable. And a suspected deep tissue injury is one where we're really not sure what's going on with it. It can present as, and we're going to go through all of these, but often it's that kind of real maroon, deep. If you think the heels, that's a great one where you see it a lot, the suspected deep tissues. So we wouldn't consider that healed because it's closed. We don't know what it is, but we're suspecting that there's pressure involved with it, and we're calling it a suspected deep tissue injury. Present on admission is present at the start of care or the resumption of care. And then for each pressure ulcer, determine whether the pressure ulcer was present at the time of the most recent sock rock and did not develop during the home health quality episode. And we're going to go through that in the next few slides. So the patient assessments are completed as close to the actual time of the sock rock as possible. And if the pressure ulcer that is identified on the sock date increases in numerical stage, meaning it's worsened, within the assessment time frame, the initial stage of the pressure ulcer would be reported in M1311 at the start of care. Does everyone understand that piece of it? That actually is one that has caused a lot of questions. The idea here is, again, we're trying to do with the Impact Act is looking at things the same way across all the various settings. And so if you go in, let's say within 24 hours, and you assess the patient's skin, and you say, oh, they have a stage 2 on their right heel. And then you go in, and it's still within the assessment time frame, right? You have 5 days for the start of care. So you go in on day 4, and now that wound is worsened and is now a stage 3. What we're asking you to do is the first skin assessment that you do, and whatever you code there is what should be coded on the OASIS. And that is so we have the same approach happening across all of the settings. That is one that's been a little hard for people to kind of swallow. It will be interesting as we go along. I think tomorrow we're going to take the opportunity at one point to do some table talk and talk about, now that this is active and up and going, what's working, what's not working, what have been your successes, what have been your barriers. And not only around this, but just in implementing some of these changes. But I can tell you those are some of the questions that have come up. So what you want to do is, you'll see if you took out if you had an OASIS sitting here, and it was too small for me to even show it up here again, but I think we have some screenshots. You're going to answer at the sock or the rock, you're going to enter responses in A1, B1, and if you looked at the form, it's A1, B2, B1, B2, C1, and you go all the way through. But when we're looking at 1311, we're just responding to A1, B1, C1, D1, E1, and F1. And we're going to enter the number of pressure ulcers that are currently present, and you can enter up to the number 9. So that actually was another question. What happens if they have 12? What can you put in? 9. So should you only document in your clinical record 9? No, of course you'd enter whatever. But the max number is that we can put in for this would be 9, which would be significant. Have you seen a patient with that many? I have, yeah. So, especially someone who had a fall and had an extended period of time on the floor and ended up in the acute care setting, and if they went back home. I've seen that. And then enter 0 if no pressure ulcers are present, and then A2 through F2 are admitted at the sock and the rock. We're not answering those questions. At follow-up or discharge, we're going to enter, again, A1 through E1, but we're also going to answer then the A2, B2, and whatnot. So when we are doing our follow-up and discharge, we're answering A1, A2, B2, or B1, B2, and whatnot. And we'll go through those questions. So again, what you want to do is enter in A1 through F1 the number of pressure ulcers that are currently present, and enter 0 if there's no pressure ulcers. And then A2 through F2, you're going to enter the number of these pressure ulcers that were present on admission. If no pressure ulcers were noted at the time of admission, you're going to put a 0. And we're going to go in, we're going to do some practice assessments around these. So here, this is starting to go through, and we're going to talk about stage 2. So stage 2 is a partial thickness loss of dermis presenting as a shallow open ulcer with red pink wound bed, key piece, without slough. So that's an important piece. So this is one where I would say to you, are you confident in your nurses or therapists or whoever's going to go out and look at wounds? Would they be able to determine, and would they accurately code a stage 2 versus a stage 3 that's pretty shallow? If it has slough, can it be a stage 2? No. How confident, you don't need to raise your hands, but how confident are you that all of your nurses who might be doing this OASIS assessment have that as a solid piece, that they really understand that? I can tell you that you may think they do. I would validate that. I would want to make sure that your staff understand that. Because if you're saying something is a stage 2 and then it decreases to a stage 3, it's now worsened, right? But what if it was a 3 all the way along, but the nurse miscoded it because he or she didn't know what they were looking at? So this is an opportunity in your action plan to say, am I confident? You might have already done competencies on this, and you might be 100% confident, and that's great. But make sure that you are looking at this. And this is an opportunity with new staff when you're bringing new staff on. So you might have done like this big initiative and all this education. Have you implemented and integrated that those critical pieces into your onboarding of your new nurses? Don't assume because they worked for 10 years in another agency that they figured out 10 years ago how to do it. They may have been taught wrong, or they may have just forgotten or whatever, and so you want to make sure that they are coding it correctly, at least in your agency. So I already talked about this, so it's without slough. This, you can also, according to the guidelines that we have, you may also show that it's present as an intact or open or ruptured blister. So it's usually clear fluid filled for us to be coding it as stage 2. Then we start getting into stage 3s, and here we have full thickness tissue loss. We have subcutaneous fat may be visible, but bone or tendon or muscle are not exposed. So that's an important piece. Now, stage 3 is an interesting kind of ulcer, right? Because it can be fairly shallow, and depending on the size of the person, it can be pretty deep without getting into bone and muscle and tendon. So it's one that's probably got the greatest, I think, variation when you start to look at measures within it. Slough may be present, but does not obscure the depth or the tissue loss in the area. So you couldn't have, if it was completely covered in slough, you would have to say unstageable due to slough or eschar, and we're going to talk about that one. And then in a stage 3, it may include undermining or tunneling. So this, you may have a wound that presents as, 4 centimeters across and 3 centimeters down, and maybe 3 by 3, and then maybe another 3. But then it could have tunneling, and if you go to tunneling, you could have 4 centimeters of tunneling. It can go away. So it's just important to understand that that's certainly a potential with a stage 3. And then we have our stage 4 pressure ulcers, and those are can be devastating ulcers. These are full thickness tissue loss with exposed bone, tendon, or muscle. They can have slough or eschar may be present on some or part of the wound bed. It often includes undermining and tunneling. If any bone, tendon, or muscle or joint capsule is able to be seen, the pressure ulcer should be reported as a stage 4. So even if there's slough and stuff, if you see bone or you see tendon, it's a stage 4. And where can we see stage 4s where they don't seem really deep? Anyone? Ear, yeah, where else? Nose, elbows, yeah, outer malleolus, okay. Maybe very different than, if someone has something on the coccyx or on, on an area on their hip, may be very different than, and as far as depth is concerned, you can very easily just get right to the bone quickly and have a stage 4 in an outer malleolus. Okay. Now we're going to start to get into some of the unstageables. So we have unstageable due to non-removable dressing or device. Now, what we want to do is code here is known, so there's known to be an ulcer present, but are unstageable due to a dressing or device such as a cast that cannot be removed to access the skin underneath. Caveat, because this came up in previous trainings. This is not to say, oh, they have a dressing, it's not due to be changed today, so I'm not going to do it. Unless you really want to make every effort to get in there and take a look at the wound that you're dealing with, if possible. Unless there's clear direction that the dressing or device should not be removed, and usually there's a physician order that says don't remove it until whatever day. You could have a primary surgical dressing or whatnot that says, it cannot come off until a particular day. Okay, now you're not able to do that. So the dressing should be removed and wound assessed unless there's clear direction. Every effort should be made to assess the wound if possible. And if there's an orthopedic device in use, follow the orders. If the device can be removed, then go ahead and remove it and then replace it. And then if there's clear you cannot remove the dressing or device and there's a pressure ulcer in the area, then you need to code the item as unstageable due to non-removable dressing. And then you'll stage it at the first opportunity that you can remove that dressing. And then remember that the OASIS should be coded with the findings from the initial skin assessment. So again, right, what if I'm out there on day 2 or maybe day 1? And now I'm out there again at day 5. Now at day 5, I can remove the dressing. I couldn't remove it at day 1, but there was really clear instructions from the physician or nurse practitioner, whatever, that I couldn't remove that. Then I have to go with unstageable due to non-removable dressing versus now I'm able to look at it at day 5. And again, the reason behind this is around consistency. We had some people who had some concerns around payment and whatnot. We're not here to discuss those, but they may come up for you as well. So it's important that even though you have 5 days to complete this, the skin is done on your initial assessment. And then unstageable due to slough or eschar, and what we're looking at here is the true anatomical depth of the tissue cannot be determined because of the slough or the eschar. The one time that you can do this, again, I mentioned this just the last slide, is if it's a stage 4. So you could have almost the whole wound covered with slough. Some eschar along the side and slough, so that eschar is that, really almost like a scab, and that slough is that tan, sticky kind of stuff that doesn't clean away. But you can see bone or tendon, it's already stage 4. You don't need to see the rest of that wound, all right? So slough is that non-viable yellow, tan, gray, green, brown, any one color that you want to add to that. It's usually moist. It can be soft, stringy. It just doesn't come off when you try to clean it. It's adhered to the base of the wound. And then eschar is usually dead, well, it is dead or devitalized tissue. It can be hard or soft, but often I describe it to people if they want to know what it looks like. It's really like a scab. And so it's usually very much adhered to the wound. It's necrotic tissue, and they usually firmly adhere to the base of the wound, and usually at that point needs to be either surgically or chemically debrided, if that's a choice that you're doing. Usually on the heels, they just let them be, and you relieve pressure and keep an eye on them. And then we have unstageable suspected deep tissue injury, and here what we're looking for is they can be difficult to detect. We're looking for that purple or maroon areas of discolored intact skin due to damage of underlying soft tissue. And again, I told you, one of the easiest ones, the one that we see most often, are on the heels. So you get that deep maroon color on the heels, but you can have this in other places in the body where there's pressure. And the area may be preceded by tissue that is painful, firm, mushy, boggy. So you see, it could be mushy, it could be boggy, or it could be firm. So you have to use your best judgment on what you're dealing with here. It could be, the surrounding tissue could be warm or cooler. And then people with a suspected deep tissue injury, if you have people who have darker skin tones, who have a lot of melanin, this can be much more difficult to identify. So what you want to make sure is that you are making sure that you have good light and that you're clearly looking at the skin. So if someone has a very dark melanin skin tone, you want to make sure that you're looking very closely at all those bony prominences, because you don't want to miss a suspected deep tissue injury. And then what can happen with these suspected deep tissue injuries is often they'll what we call define themselves within 48 to 72 hours, and they kind of tell you what they are. They just progress rapidly. And once the tissue, it usually opens up, it starts, you can start to get a sense about what it is. You can think something's going to be a stage 2, just superficial, and all of a sudden you get that tissue reveals itself, and you could actually have a stage 4 underneath there. All right. So we have our first of our polling questions. So if you have your little devices, is everyone still awake? Yeah? I know this is hard, guys. I'm going to make you all do jumping jacks shortly, but okay. So take your little devices here, and for the SOC rock assessment, a response is required for M1311 A2 through F2. So tell me, is that true or is that false? Ready? All right, so we have majority of the people have it correct. So remember that the A2 and F2 are, do not happen at the SOC and the rock, and that happens at the end of the quality episode, at the discharge assessment. So A2 through F2 are not done at the SOC and the rock. And it's the discharge or the follow-up you're required to answer the M1311 A1 through F1, and then the A2 through F2. All right, hold on to your clickers. And again, you have one clicker at a table, so if you want to have a little conversation, I'll give you a short period of time so that the table is answering. Okay, so at the SOC, the assessing clinician determines that Mr. T has an unstageable pressure ulcer due to coverage of the wound bed by slough. The next day, the pressure ulcer is debrided and assessed as a stage 3. So, how would you complete M1311 at SOC? Got it? Everyone's arguing at their table? Okay, let's see. All right, most of you've got it correct. The answer is C. And so what's our coding rationale here? Well, you'd enter 1 for M1311E1, which is unstageable due to slough or eschar, and enter 0 for A1 to D1 and F1. So if an initial skin assessment completed on admission to home health services identifies a pressure ulcer, the stage of that pressure ulcer as identified at that initial assessment is what is encoded. Any subsequent changes to the numerical stage would be reported on subsequent OASIS assessments. So since this wound was unstageable, pressure ulcer, and it was identified as part of the initial assessment, the ulcer should be reported as unstageable on the SOC, on this particular SOC assessment, regardless of whether the subsequent debridement and stageability of the initial, after the initial skin assessment. So this is the one, again, this is an opportunity for you to go back to your staff and say, are you confident, or as you sit here today, that if this happened for one of your clients, would your nurses, because they have 5 days to complete that, would they be coding this as that stage 3, or would they have done it unstageable? Again, you don't need to raise your hands, but think about that, and then put that on your action plan as something that maybe you want to go and validate. You can randomly just ask some nurses when you go back to your agencies. Okay, so we have another. So keep your coding devices. At the SOC, Mrs. P is noted to have 3 clear fluid-filled blisters, try to say that quickly, on her mid-abdomen. Her skin is otherwise dry and intact. After reviewing her medical history, the assessing clinician noted that Mrs. P has the following diagnosis: congestive heart failure, chronic obstructive pulmonary disease, and epidermolysis bullosa. So, let's think about this patient. The SOC assessment for M1311 should document a presence of 3 stage 2 pressure ulcers. Everyone have this one? Yeah? What do you think? True or false? You guys are good. Okay, most people got it correct. This actually came out of a couple of Q&As. So there were staff members who were at one of our trainings who said, well, wait a minute, I have a couple of patients who have that diagnosis, and I've been coding those all as stage 2s. Would that happen in your agency? So think about it. So some of the stuff that we're doing, actual questions, are ones that have come forward in previous trainings or come through as in our Q&A database. So that is a disease process. So we wanted to make it really clear. So that's the reason it was mid-abdomen. But I had started this, actually, this scenario as the outer right thigh. And then it was, well, wait a minute, you're not giving us enough information. There could be pressure involved with that. It could be a whole bunch of other things. And so, in fact, just for the training purposes, we went with the mid-abdomen, where more likely than not there was no pressure involved, and that this was part of her active disease process that this particular patient had. But so again, a training opportunity when you go back to your organizations. What are the disease processes are going on with your clients that may present as something that looks like or may be a pressure ulcer. But in this particular situation, the mid part of the abdomen for this particular patient, there was no pressure involved with it, right? Okay. And so we basically, we told you that the blisters are associated with the epidermolysis bullosa diagnosis and are not a result of pressure. It's a disease causing blisters, if you didn't know that. How many people have seen that? It's pretty fascinating. Yeah, it's a pretty fascinating disease. Thank God I don't have it. Anyway, the etiology of the blisters is not a result of pressure. And then, but please know that someone with epidermolysis bullosa can certainly develop a pressure ulcer. So I'm not just saying so it's not an absolute yes, no. Just because they have this diagnosis, could they still get a pressure ulcer? Of course they could. So, often as clinicians, and it doesn't really matter what healthcare setting you are, everyone's kind of running at 100 miles an hour. And if they're not critically thinking, if they're not peeling back the onion, they're not thinking through all of these, you can see where you could get some inaccurate information on your assessments. And then you'd say, well, wait a minute. All of a sudden, now you're putting in this huge quality improvement initiative, and you're going down one whole road when it's really just people are not understanding how to assess and accurately code something that's a pressure ulcer. So if you went down a whole different road around education, you would have missed the mark because you didn't understand what was driving the problem in your particular organization. So M1311, what are some of the data sources or places that you can get information? Well, certainly patient caregiver interviews would be helpful, especially if you're being a detective to try to figure out if there's pressure related. Where's the person, where do they sit, what kind of chair? If someone's gained weight and now they're in this little wheelchair, but that's the chair that they're in all the time or whatever, or they sit in a chair at the kitchen table and they spend hours doing crossword puzzles or whatever, and you realize that they've gotten a little large for that chair, and they've got areas that are constantly putting pressure maybe on their hips or whatnot. It's important to look at that. Observation, it's very, very important to look around to understand what kinds of splints that someone may have on, what environment they're in. Doing your physical assessment, certainly your clinical record review and your history, any referral documents that you have from the hospital or the previous care setting, talking to your physician if the patient has been in and that particular physician's been involved with the care. Often I know in home care, by the time you get them, if they've been in the hospital and maybe in a skilled nursing facility and then you're getting them and you're calling their primary, what are they saying to you? I don't know. I didn't have any idea they were even in the hospital. So that they may not know what's going on. So you may have to help inform with the physician what is going on with that patient. And then certainly always make sure that you refer to the OASIS Guidance Manual. Chapter 5 will help you in encoding any of these items. So for 1311, some of the tips. So let's talk about some of these. A previously closed stage 3 or stage 4 pressure ulcer that is currently open again should be reported at its worst stage. So if you had a stage 4 pressure ulcer on the right trochanter, it's closed. Remember I talked about that, right? So that's considered healed. And then it opens up at that exact spot, that exact area. So it opens back up again. It is, then you would code it at its worst stage. The same way that you want to make sure that if someone was in an inpatient setting, and let's say they had a stage 4 or stage 3 pressure ulcer, and they went from the acute care to the skilled nursing, and by the time you get them, it appears to you, looking at it as a clinician, that it's a stage 2. Would you code it as a stage 2? Yes? No? This would be a good, I guess, polling question. No, you really want to, so what we don't do is we don't reverse stage. So it is always a healing, let's say it was a stage 4, it's a healing stage 4. So what you're seeing clinically, so it might have starting of epithelialization, it really might not have any depth, it's done a nice job, it's healing beautifully, but it still is a stage 4 pressure ulcer. And what do we know about healing ulcers? When we heal an ulcer, do we put back the exact same tissue that was there prior? No. Lower tensile strength, exactly. So meaning that tissue is about 80% capacity as what it was prior to what you were born with, intact. So there's scar tissue and whatnot that's healing in it, and it's a complex process to completely heal a pressure ulcer. And there's still a lot of science that's being researched around that whole healing of ulcers. So it's important to remember that when you take in and you have someone who has a skin issue, it's going to be very, very important for you to find out what was it, if you can, what was its deepest stage. So if it came from the hospital to the skilled nursing and the skilled nursing to you, can you get a hold? Now, the skilled nursing is going to do the discharge, right? They should, in fact, be telling you it's a healing stage 4. But if there's any question, if you can go back to the skilled nursing to have them look at their referral documents from the acute care setting and to figure out what that ulcer was. That's going to be very, very helpful to you. And so basically that's what that says. So contacting your previous provider if you can to get this information. So reverse staging, we always consider the historical information on the pressure ulcer. When we perform the skin assessment, we don't reverse stage. Again, I challenge you. How many of your staff members, if they went out and they assessed someone with a wound that appeared to be a stage 2, would quote it as a stage 2 and not even bother to look at what the original staging of that was? Do that gut check yourself, because that, I think, is an opportunity for you to be able to go back to your organizations and check that out. Reverse staging is clinically inappropriate because the pressure ulcers do not heal in a reverse sequence, and we already talked about that. And the body doesn't replace the types and layers of tissue, meaning muscle, fat, and dermis that were lost. We end up having scar tissue. And then improvement in healing can be captured at M1320. We're not going to really go through that, but that came up as another question. Well, where do I capture healing of this? Well, at 1320 is where you can do that. So this is, again, I think, a nice opportunity for you to go back and, along with these other things, as we add these tips, is say, all right, what would my staff be doing? So why is it important that you wouldn't want your staff member to code that as a stage 2? Why do you think that would be important? Anyone? Right, what if it got worse, right? So, I mean, the slightest little thing could take that fragile tissue that now appears as stage 2, but if that was originally a 4, what did I just say, right? It takes an extensive period of time to cause the scar tissue and build that all up, but even at that tissue's not the same. So the risk of that opening back up and becoming a stage 4 again from what appeared to be a stage 2 can be fairly great. So you wouldn't want to all of a sudden take credit from a stage 2 going to a stage 4. What's that going to say about your quality? Right. I have people going like this. Right. And in fact, is it? Did you do anything wrong? Probably not. You probably want to look at it. Did you have the right surfaces? You could do your own due diligence, but think about it. That wound was at risk. It was let's say it was a fairly recent injury that over the last 3 months prior to coming to you in home care, that was healing. I've seen wounds out at, 5-6 months open back up again. Have a changing condition, all of a sudden, boom, it opens right back up. So again, an opportunity to make sure that we're not gaming the system, but we're having an accurate assessment, and we know exactly what's going on with our patients so that we have accurate information on them. So let's talk about a muscle flap, a skin advance flap, rotational flap, performed to surgically replace the pressure ulcer, is now a surgical wound. I'm not talking about debridement. I'm talking about a surgical procedure to replace that pressure ulcer. And it should not be coded or reported as a pressure ulcer at M1311. So if they had a flap done in a stage 4, and are people seeing that? I would imagine you are. I mean, I know they're seeing it in skilled nursing, so I can imagine you're seeing it in home care. So once you have that surgical procedure done, the pressure ulcer piece of that is gone. It's now a surgical wound. A pressure ulcer treated with a skin graft should not be reported as a pressure ulcer, and until the graft edge is completely healed, should be reported as a surgical wound. So now we have a couple of caveats. We have let's say we did a muscle flap. Let's say another patient, we did the skin graft. Now these are not pressure ulcers. These are surgical wounds. How confident are you that your staff, knowing that that was a stage 4 and then they had the muscle flap, we'll code that as a surgical wound versus a pressure ulcer. And if your answer is, I'm not sure, an opportunity to go out and validate that with your staff and educate. And then a pressure ulcer that has been surgically debrided still remains a pressure ulcer. And we will see that, especially with these large and involved ulcers. They'll go in, they will debride and take away dead and devitalized tissue. It still remains a pressure ulcer. And that would not be reported as a surgical wound at M1340. Does that make sense to you? Okay. We're almost to a break. Let me see how many practice scenarios I have. All right, we'll do practice scenario 1. So what I'd like you to do, if you could for me, and then we're going to take a break. So if you can take your quality reporting program practice scenario sheets, that looks like, well, yours is in color, mine's in black and white here. It's in your folder on your right-hand side. It's towards the back of the folder, if you haven't already pulled it out. Take that. The first page on the top says M1311 practice scenario 1. So we actually are going to go through this practice scenario, and I'm going to have you code the situation that we're going to give you. And so practice scenario 1 is just on the first page. Are you ready? Everyone have their papers? Okay. And again, these are great scenarios to take back to your organization and try these maybe during a staff meeting and see how people do, or an education session. And you can, tweak these and change them and take current patients or past patients that you have, but you'll get an idea how we went about them. All right, so practice scenario 1. So this is your patient. At the start of care, the patient has 3 small stage 2 pressure ulcers on her sacral area. Upon discharge, the sacrum is assessed. 2 of the stage 2 pressure ulcers have merged, and the 3rd ulcer has increased to a stage 3. So take your sheet. I'm going to give you a moment. The key bullet points are on the top above the coding, and just go ahead and code this as if this was your discharge assessment. So answer each one of the questions there. Just give another moment. Most people are almost done. Okay, how are we doing? Okay? Can we go through? All right, so let's look at the coding. So this is exactly what you're going to see on your scenario, coding scenario. So let's look at M1311A1, number of stage 2 pressure ulcers at the sock rock. 3? Good. 3. Does everyone get that? Is that it easy? That wasn't easy. That was a give. Okay. So then the next question is the number of stage 2 pressure ulcers at discharge. Okay. Ready? 1. So why? I heard a lot of 2s. So at the start of care, the patient had 3 small stage 2 pressure ulcers, right? Upon discharge, 2 of the stage 2 pressure ulcers merged into 1. And what does that mean when they merge together? They're counted as 1 then, okay? So often you'll see 2 that are close together with a little bridge of skin, and sometimes that skin will go away. It's still a stage 2, but now the surface area becomes as 1. You now count that as 1 ulcer. Is that Everyone understand that? Yes? Okay. So then the next question is the number of these stage 2 pressure ulcers that were present at the most recent sock rock. Got it? What are we thinking? I'm not hearing a lot. 1. So why? So remember what the language is saying here. The number of these stage 2 pressure ulcers. So when it says these stage 2s, what are they referring to? The one right above it, right? It's saying of those that were present upon discharge, how many of those were present at the most recent sock rock? So in fact, in this scenario, we had 2 of the stage 2 pressure ulcers have merged. So it's still, there was one, now we have 1 stage 2 pressure ulcer. So it's saying that that stage 2 pressure ulcer was there upon the admission, all right? And now it's asking how many of those were present upon discharge. And we're saying 1 of those. So that 1 ulcer. Okay. Oops, I gave you the answer to the next one, sorry. Number of stage 3 pressure ulcers that were present on the sock rock. 0. Okay, I gave you that one. Number of stage 3 pressure ulcers that were present on discharge. 1, correct. Now, number of these stage 3, so we have that 1 on discharge, how many of those stage 3 pressure ulcers were present at the most recent sock rock? 0. Very good. So we had 0. Is that helpful? We're going to go through a bunch of these because I think that's what helps like bring it all together for you. Just very quickly, and then we'll take a break. So we talked about this. 2 of the pressure ulcers on the sacrum have merged, but they remained at the same stage. They were at the start of care. And then the pressure ulcer that increased in numerical stage to a stage 3 has developed a deeper level of tissue damage since the start of care. Therefore, on the discharge assessment, it is the M1311 B2 is coded as 0, not present on the most recent sock rock. And that's where they start, when you think about understanding the numerators and denominators, new and worsening. So in this situation, that's where it's comparing kind of admission to discharge. What we noticed is one of those ulcers actually worsened. And that's how it's looking at it from a quality perspective for this particular patient. All right, so we have a break. It is a little after 3, so we have a 15-minute break. So, and then we'll wind up. We have another, I think, 40 minutes once you get back, 45 minutes, and then we're going to go to Q&A. So we'll see you back here in 15 minutes. All right, everyone, we're going to get started again. So we have a lot more material to go through, a lot more practice scenarios and whatnot, and we need to be ready for Q&A by 4 or a little after 4. Okay, so practice scenario 2. So if you take your coding sheet that you've been working on, flip it over, and then you have practice scenario 2, and you'll just follow this sheet through. So this is practice scenario 2. And let's look at this, and then we're gonna, we'll go through the process. We'll go through the scenario. I'll give you a minute or two to code, and then we'll go through the coding together. So at start of care, Mrs. J is admitted with 4 stage 2 pressure ulcers and 1 stage 3 pressure ulcer. So this is someone who has 5 ulcers. And during Mrs. J's home health quality episode, 3 of the stage 2 pressure ulcers healed. However, Mrs. J develops an additional stage 3 pressure ulcer. So you got the scenario, and it's actually written on the top of your sheet. So go ahead and do your coding. We almost done? Okay, all right. So in this scenario, let's just remind you that the patient was admitted with 4 stage 2 pressure ulcers and 1 stage 3. And then during their stay, with your home care agency being involved, 3 of the stage 2 pressure ulcers healed. However, Mrs. J develops an additional stage 3 pressure ulcer. So, M1311A1, number of stage 2 pressure ulcers. 4, correct. Number of stage 2 pressure ulcers at discharge. Very good, great. All right, then number of these stage 2 pressure ulcers that were present on the most recent sock rock. Very good. Number of stage 3 pressure ulcers at the start of care. Good. Number of stage 3 pressure ulcers at discharge. You guys are smart. Okay. And number of these stage 3 pressure ulcers that were present at the most recent sock rock. Right, okay, good. All right, so you've got that down. Very good. So there were 4 stage 2s. The patient had 1 stage 3 pressure ulcer at the start of care and then developed 1 more, so that's how we ended up with 2 at discharge, and only 1 of them was new. So that's how they're going to capture that new or worsened. All right, none of them worsened of the ones that they had, but they developed 1 new one. All right, so now we have scenario 3. And again, practice scenario 3, the scenario is going to be up top. And then your coding, this is one's a little bit more involved. So at the start of care, Mrs. P was admitted with a diagnosis of a cerebrovascular accident, or CVA, with right hemiparesis and assessed to have a 1 centimeter by 1 centimeter by less than 0.1 centimeter stage 2 pressure ulcer on her coccyx. Mrs. P continued to decline at home with decreased appetite, frequent transient ischemic attacks, and wishes not to be hospitalized again. After a palliative care consult, the patient and family agreed to hospice care. Upon discharge from home health care, Mrs. P was noted to have a pressure ulcer completely covered with eschar on her left heel and a stage 3 pressure ulcer 3 centimeters by 2 centimeters by 0.4 centimeters on her coccyx. So let's go ahead and code this scenario. This has a little bit more. Hard to read here, but you have it in front of you. Yes, I think that's the assumption. So the assumption was, is the stage 3 in a different area, and it's the same area, the coccyx, where she had the stage 2. It's the same, we'll make the assumption here, it's the same ulcer. We almost ready to go? No? Yes? Okay. All right, so let's go through this practice scenario. So the number of stage 2 pressure ulcers at sock rock. Okay, good. Number at discharge. Good. How about the number of these stage 2 pressure ulcers that were present at most recent sock rock? Well, actually, it's a skip. That was a little bit not a trick, but what would happen is if you were, doing this in your computer system, whatnot, it should be programmed right in. It would be a skip. All right. So you would skip the item, because if you don't have any, you can't say how many of these were present. That's really what the caveat is around that. Okay. Sorry, I went. So number of stage 3 pressure ulcers on the sock rock? Right. Number of them at discharge? 1, correct. Okay. And then, let's see. Number of these stage 3 pressure ulcers that were present at the most recent sock rock? Right, 0. Because, so what it's showing is worsening. They didn't have the stage 3 when you started the care, right? So how about the number of stage 4 pressure ulcers? Sock? How about at discharge? Okay. How many of those stage 4s were present on a skip? Okay, really is what that one is. Okay. And then number of unstageable pressure ulcers, non-removable dressing. Right? How many of those at discharge? Good. Okay. And then how many were present at the most recent sock rock? 0, or skip on that one. Okay. Now, number of unstageable pressure ulcers due to slough or eschar at the sock rock? Correct, 0. Now, how about at discharge? 1, correct. And number of these unstageable pressure ulcers that due to slough and eschar were present on the most recent sock rock? Correct. Okay. And then how about the number of unstageable pressure ulcers due to deep tissue injury? Okay. How about a discharge? Right. And then how many were present on admission? So, okay. They put a 0 in there. It actually should be a skip. All right. So really what we're looking here is the stage 2 pressure ulcer on the coccyx was present at the start of care but deteriorated to a stage 3. And Mrs. P also developed a new heel pressure ulcer during her home health quality episode that was unstageable upon discharge due to eschar. So we just need to say it was unstageable. Okay. So now let's spend a little bit of time looking at M1313. And you'll see where there's crossover with these, because these are now, we've kind of done the A1s all the way through, and then the A2s. So in C1, M1309 was worsening in pressure ulcer status since the sock rock, and then that's the same in C2, but the item number has changed, so from 1309 to 1313. If you remember, this is what the item looked like on the previous assessment, the OASIS-C1, and this is what it looks like here. And what you'll notice is there's 2 areas that are highlighted here. And then these are the unstageable categories now include unstageable, known or likely, but unstageable due to non-removable dressing. And then E, you always did, which was unstageable, known or likely, but unstageable due to coverage of wound bed by slough or eschar. And then you have the new one, which is F, unstageable, suspected deep tissue injury in evolution. So these are new items, or new areas or questions that you have to answer. So you want to, the intent here is to document the number of pressure ulcers present at discharge that were not present, meaning they're new, or have worsened, increased in numeric stage, since the most recent start or resumption of care. Okay, so when we're looking at the time points, discharge is within 2 calendar days of the date of discharge. You know that. So review the history of each current pressure ulcer. This is where it's going to be really important to understand what you actually coded at your sock rock. Compare the current stage at discharge to past stages to determine whether the pressure ulcer currently present that you see now is new or at an increased numeric stage, worsened, when compared to the sock rock. So this is a comparison measure when you're looking at the 2. Then for each current stage, count the number of current pressure ulcers that are new or have increased in numeric stage since the last sock rock was completed. So for pressure ulcers that are currently stage 2, 3, or 4, mark a response for each row in this item A, B, and C. If at discharge there are currently no ulcers at the given stage, enter 0 for that stage and row, and report the number of current pressure ulcers at each stage that are new or have worsened since the most recent sock rock. So what we're going to see here, these are reporting algorithms, and these come right out of the OASIS manual. Who's seen these in the manual? A few of you have read your manual. Great. So these are algorithms that can walk you through. We actually found a couple arrows that we thought should be added to these, so we've made those recommendations. But so really what you want to do here is if you're trying to read these, in the far left you have a stage 2 at discharge, so this is the current stage at discharge. The look back to the most recent. If it's the same pressure ulcer at the most recent sock rock was, and then you go into the next row, which is the third row over, which is the prior stage at the most recent sock rock. And then it's telling you whether you should report it as new or worsened. So if it wasn't present, what is it? And it's there now, it's present, right? It's new, okay? If it was a stage 1, and you see it now, what is it? Worsened, right? If we're saying stage 2, if it was a stage 1, now it's a stage 2, it's worsened. If it's covered with non-removable dressing or device that documented as a stage 1 at the home visit or follow-up assessment, and then it goes through stage 2, 3, 4, and then all the way through. So these algorithms are there. We wanted to just tell you that they're in there for stage 2, stage 3, and stage 4, and also for all of the unstageables. What I've found when we've talked to people is some people find them helpful, others say, you know what, they are so confusing, I choose not to use them. So, but they're there as a resource for you, and they are in the manual. So we just present them here. I don't need to, you can read them, I don't need to read them to you. Okay, so let's talk about the use of the dash related to M1313. So a dash value is a valid response for this item. And a dash value indicates no information is available and or an item could not be assessed. So this is not replacing a 0. So this is saying I don't have any information here, so I can't judge this. This most often occurs when the patient is unexpectedly transferred or discharged or dies before the assessment of the item could be completed, and not specifically for these items, but for other items throughout your assessment. So this is just talking about using a dash as a valid item. And CMS expects dashes used to be a rare occurrence, but it is a valid response. And I think if I remember correctly, dash is fairly new for home care. Okay, it's been used in other settings for years. So for home care, I know this is something new. So you just want to make sure that staff understand when it's appropriate to use a dash. So the idea is, if all else fails and you can't get the information, you just don't know because you can't get the information, you have to put a dash in, right? And that is a valid response. But we also want to make sure that it's just, not used willy-nilly and just put it in because you don't want to do some due diligence and you don't want to, go through previous discharge records or information that was sent from another setting. So also remember that M1313 is not completed on transfer or death assessments, so the dash should rarely be used for this particular item. But I think it just takes the opportunity to first talk about dash, and I think Kathy and Ann, when they present tomorrow, certainly will address the issue using dash in some of the other items. So again, for 1313, remember we're never reverse staging pressure ulcers as a way of documenting healing, as it does not accurately characterize the physiologic occurring at the ulcer as it heals. And once the pressure ulcer is fully granulated and the wound surface is completely covered with the new epithelial tissue, the wound is considered healed and should no longer be reported as an unhealed pressure ulcer. So that's that idea of closed. So remember that when we're educating your staff related to completing the OASIS. We had some conversations with some people who came up, providers that came up during the break, and talked about some slight difficulty in educating on what should be put in the clinical record versus what should be coded on the OASIS. But we use the OASIS manual and the Q&As to go ahead and actually encode the OASIS. So some of the tips: a previously closed stage 3 or pressure ulcer that breaks down again should be staged at its worst stage. So that's important. Where we already talked about that, why it's so important to find out what was its deepest anatomical stage if you can find it. If the pressure ulcer was unstageable for any reason at the most recent sock rock, do not consider it new or worsened if at some point during the sock rock and discharge it becomes stageable and remains at the same stage at discharge. So what does that mean? So I go in today, I do my assessment, I have a doctor's order that says I can't remove that dressing, but I know they talked about that there's a pressure ulcer under there. So now, however many days later, I now have permission to remove that dressing. I go in, and now I can stage that ulcer. Let's say it's a stage 3, that pressure ulcer. And throughout my care of that patient, let's say it stays a stage 3, and at discharge, it's a stage 3. What this is telling us, it's not worsened because you didn't know what it was initially. All right, the first time that you looked at it, you staged it, and now as long as it stayed at that same stage, it's not considered worsened at discharge. Does everyone understand that? That's what that bullet is talking about there. So if a pressure ulcer was unstageable at the sock rock, then was stageable on a routine visit and or follow-up assessment, and by discharge the pressure ulcer has increased in numeric stage since the routine visit or follow-up assessment, it should be considered worsened. So same example, I couldn't assess it initially, had that dressing on it, I couldn't take it off. I take the dressing off, it's a stage 3, I continue to monitor it, and then by the time it discharges, it's a stage 4, it's considered worsened. That makes sense, right? Because it was a stage 3, now it's a stage 4. If a previously stageable pressure ulcer becomes unstageable, then was debrided sufficiently to be restaged by discharge, compare its stage before it was deemed unstageable, and if the pressure ulcer is stageable, pressure ulcer stage has increased in numeric staging, reported as worsened. So let me give you that scenario in layman's term. Stage 3 on start of care. It becomes, let's say, completely covered with slough or eschar. It gets chemically or surgically debrided, and now it's a stage 3, okay? It was a stage 3, went unstageable, still a stage 3. Now if it's cleaned up, it's not considered worsened. If it's stage 3, becomes unstageable, we clean it with chemically or it gets debrided, now it's a stage 4, it's worsened. Does that make sense to everyone? Okay, good. Okay. All right. So again, the same data sources, we've already talked about these. Again, very important to get some of the referral documentation. We were talking again during the break how important that is, especially if you're doing the due diligence to the best of your ability. Can you get the discharge summary a copy of the discharge summary from the hospital, a discharge summary from the skilled nursing facility? If you have it, call and talk to someone if you have that opportunity. Probably able to do that more easily in a skilled nursing facility, but maybe you could talk to a case manager if they're coming out of the hospital. But it's a matter of doing that due diligence, again, around those wounds so that you have an accurate picture. So now we're going to finish up my session here, and then we're going to go to Q&A around doing some practice scenarios. So if you take your practice scenario sheet and and what you're going to see here is you're going to see, flip through, I think it's 2 pages, you're going to see a sheet like this, and it says M1311 and M1313 practice scenario 1. Pull that out, just kind of flip through, because that's what we're going to use. So in this scenario, and again, the scenario is written on the top of your sheet just in case you can't read the type up here. A patient was admitted to home care from the acute care hospital with 2 stage 2 pressure ulcers with clear fluid-filled blisters, 1 on each heel. After a few days, the left heel, stage 2 blister, has ruptured and presents as a shallow ulcer with a pink wound bed. The right heel continues to evolve, having a blood-filled blister and matured into a color from a red to a maroon/purple color, and with the area surrounding the blister being boggy, painful, and warm. The patient stated she was moving and going to stay with her daughter who lives 2 hours away. She was discharged to another provider. Upon discharge, the left heel had a shallow ulcer with pink wound bed. The right heel was covered in a firm, dark eschar with a slight bogginess around the eschar. So here you have a situation. So they were admitted. They then make the decision they're going to move in with their daughter a couple hours away. They're discharged from your service. They're going to go with their daughter, and then there'll be home care, hopefully, when the daughter picks them, starts to have the mom live with them. So you have the scenario. Take a minute and go through and answer the items here for M1311 and M1313 around this particular case. How are we doing? Okay? See people still working. We'll give it another minute. Okay. All right, so let's go through this scenario. So let's start with the number of stage 2 pressure ulcers at the sock rock for this particular patient. Correct. My paper is wrong. Okay. The number of stage 2 pressure ulcers at discharge. Okay, good. Let me just, I'm sorry, let me go. Okay. All right. So then I have, let's see. Okay. So that's correct. So the number of these stage 2 pressure ulcers that were present on the most recent sock rock is 1. Number of stage 3 pressure ulcers on the sock rock? Okay. Number at discharge? Right. Okay. How many of these were present on the sock rock? 0 or skip. Okay. How about worsening and pressure ulcers since status stage 2? So we're not asking all the questions here. We kind of blacked out some of them. So on discharge, so M1313A. Okay, so saying worsening in pressure ulcer status in Sacral stage 2. So let's see what we said here. So we have one of the ulcers is still a stage 2, correct? Right at discharge. And then the other one ended up being evolving into a having eschar. Okay, we're going to go through. So so what ends up happening here is one of these wounds, the stage 2, went to unstageable. So we don't know what stage this ends up. So in stage 3, we have 0, right? And then stage 4, we have 0. And the unstageable, due to non-removable dressing, is 0, right? How about for eschar? 1, okay? And then worsening in pressure ulcer status since the sock rock, unstageable, due to deep tissue injury. 0. So what ends up happening? On discharge, she has eschar on that heel. So until that eschar is removed, right, we don't know what's on stage. We don't know what it is. Right, worsening in pressure ulcers since sock rock. So it's new or worsened. I would code that a 1. Yeah, you don't know that it's worsened, right, because it's eschar. Yeah, we don't know what it is underneath there. But there'll be those that could argue the fact that if it has eschar and it's a stage 2, just for the fact that it has eschar means that it's probably worsened. Because stage 2s don't have eschar, right? All right. Let me think about that one as we go through this. All right. So let's look at a second scenario here. Well, let's actually look at the rationale here for this particular scenario. So M1311 stage 2 is coded as 1 at discharge as the left heel remains at a stage 2. We know that one. No one's questioning that. The 1313E, unstageable due to coverage of the wound by slough or eschar, is coded as 1 since the right heel was a stage 2 on the sock rock and now has worsened to an unstageable due to eschar. And the stage 1 pressure ulcer, skin intact, or stage 2 pressure ulcer, partial thickness, is always considered worsened if covered by slough or eschar, as it is now a full thickness wound. So, so what we're saying in this scenario is, so the left heel is fine, we got that. That right heel that went from that stage 2 is now we're saying is actually worsened. And this is the scenario where we can say it's worsened because it's covered in eschar, because a stage 2 never can have eschar or slough in it, correct? Where are my wound care people? Correct? Yes. So the fact that we have eschar tells me it's minimally at least a 3. Could be a 4, but it's at least a 3. It's worsened than a stage 2. So that's where we're saying it's actually worsened, because we know that a stage 2 that evolves to the point of having slough and eschar minimally is at a stage 3 or greater. So we know for a fact it's worsened. That's a real fine line in making sure your staff understand that one. Questions on that one? Thoughts? Okay. But that's the rationale behind behind that one. If you just you can. We only have one more scenario, so if you want to just go up to the microphone, just so everyone can hear, and they can hear it on the.
Just real quick now, the way I read that, it sounded like one of those stage 2s was the evolving deep tissue injury, and then the next little bullet said after a few days, it changed and evolved to having blood-filled blister, which is definitely a deep tissue injury.
Suspected deep tissue, correct.
Right. So I was thinking, since it can take 5 to 7 days for a suspected deep tissue injury to evolve, that if we assessed it at the start and then in a few days, which probably would be within the 5-day period before we submitted the start of care, we would see it as a deep tissue injury.
So the point is well taken, but think about this, right? We talked about the start of care being that initial thing, and what this patient presented at in your first skin assessment was 2 clear filled blisters. Something else happened in that other heel that then caused it to evolve, whether there was not pressure relief or something else that was going on. It didn't present initially as a suspected deep tissue injury. It presented itself as a stage 2 with a clear filled fluid blister. And then it just gives you additional information. A few days later, now we see that it has blood in it. So now it's a suspected deep tissue injury that, in fact, then that blood blister, just ended up forming into eschar, which happens frequently in these particular types of wounds. But what we saw is initially it was a stage 2. It didn't present as one being a clear blister on the left, and then the other heel showing kind of, what appeared to be a potential for suspected deep tissue. As we know it here, as it's presented here in this case. We don't have a lot of description around the surrounding tissue and all of that other stuff.
Okay, thank you.
Okay. All right. So let's go through. We have, I think, just one more scenario. No, we have 2 more scenarios. So let's go through these quickly because we're almost done. So again, if you go to your form, you have practice scenario, just the next sheet, for scenario 2. And here we have, at Sock Rock, Mr. Y is noted to have a stage 3 pressure ulcer on his right hip. During the home health quality episode, the pressure ulcer identified at the start of care closes, but Mr. Y develops a new stage 3 pressure ulcer on his left hip. At discharge, Mr. Y has 1 stage 3 pressure ulcer on his left hip. So if you just take your form and let's quickly look at that and code it, and then we'll go through the answers. We ready? No? Okay, let's go through this together. So on this particular patient, number of stage 2 pressure ulcers at the Sock Rock, right? Number at discharge, okay. And then number of these stage 2 pressure ulcers on the most recent Sock Rock. It's a skip, right? Okay. Now we're getting into 1311B1, number of stage 3 pressure ulcers on the Sock Rock. Correct. Number at discharge. Correct. Okay. Number of these stage 3 pressure ulcers that were present on the most recent Sock Rock. Very good. Very good. Great job. Okay. And then worsening. Now we're into the 1313 questions. So worsening of pressure ulcer status in Sock Rock stage 2, right? How about stage 3? He has a new stage 3. Remember, it's new or worsened. So we had the one, and then it healed, but he developed a new one on the other hip that wasn't present on start of care. Okay, so it's new or worsened. So this one can be a little confused because if you look at the wording, it just says worsened, right? It doesn't say new or worsened. But in fact, that's the definition. It's new or worsened. Okay, how about stage 4? Correct. Unstageable due to non-removable dressing. And then how about eschar? And then how about deep tissue injury? Okay, good. And then, so the rationale behind this is the SOC assessment, 1311B1, is coded as 1 because a stage 3 pressure ulcer was present on his right hip, right? Then on discharge, 1311B1 is coded as 1 and 1311B2 is coded as 0 because the new stage 3 pressure ulcer developed on the left hip during the home health quality stay. And then the 1313B on the discharge assessment because the left hip stage 3 ulcer noted at discharge was not present, so meaning it's new on the SOC rock. So the takeaway from this, the agency has to determine whether the stage 3 pressure ulcer identified at discharge is the same stage 3 pressure ulcer that was present on the SOC rock. So this is a good kind of, into the minutia when you're doing training. And it's important to track each unique pressure ulcer rather than tracking the overall total number of pressure ulcers at each stage so that you can appropriately code these. We have one more scenario and then we're done. Okay, so scenario 3, and you have it in your packets here. A patient was admitted to home care with 2 stage 2 pressure ulcers. A mutual decision was made to transition the patient to hospice care. By the time of discharge, the 2 pressure ulcers had merged and increased to a stage 3. So this is going to be a polling question. A little easier. So take your polling device. We wanted to mix it up a little bit. Okay, so why don't you go ahead and code this. How would you complete M1311 at discharge for this patient? Which is the correct coding? You ready? Everyone locked in? It's hard for me to tell. Looks like the majority of people have locked in. Oh, so we have mixed results here. And the answer is B. Okay. And I think we have, and then let me ask you one more question, then we're going to go through the rationale. How would you code 1313 for this same patient? People still answering? Okay, looks like we have the majority of them. Very good. Excellent. Okay, so the rationale behind this, at the time of discharge, the 2 stage 2 pressure ulcers that were present at the start of care merged together. Okay, so now they're one ulcer, but it increased to a stage 3. Went from a stage 2 to a stage 3. Therefore, 1311A1 is coded as 0, and 1311B1 is coded as 1 on the discharge assessment. Since the 2 stage 2 pressure ulcers merged to a stage 3, the ulcer is no longer considered as present at the start of care. So at discharge, M1311B is coded as 0. And then since the 2 stage 2 pressure ulcers merged and worsened to a stage 3, the pressure ulcer during the home health quality episode at 1313B should be coded as 1 on the discharge assessment. All right. This is another very quick coding scenario. And this is going to be, you're just going to do a polling on this. A patient developed a stage 3 pressure ulcer during their home health quality episode. And the wound bed was subsequently covered with slough, hence the pressure ulcer became unstageable. The patient record indicated that the wound debridement was performed on a stage 3 pressure ulcer 2 weeks prior to discharge. During the discharge assessment, the wound bed was observed and numerically staged as a stage 3. So how would we code this patient? Okay, people are putting in their answers. Okay, so we have a mix on this. We're going to go through the rationale. The correct answer is B. We have one more question, and I'm going to go through the rationale on it. How would you complete M1313 for this particular patient? Okay. So this one, a lot more confident on this. And so most people were correct. So let's go through what the rationale here was. So on the discharge assessment, M1311B is coded as 1, and M1311B is coded as 0, because the stage 3 pressure ulcer developed during the home health quality episode and was therefore not present at the start of care or resumption of care, right? Then 1313B1 is coded as 1 on the discharge assessment because the stage 3 pressure ulcer is noted at discharge. The ulcer developed during the home health quality episode. It was debrided and reassessed as a stage 3, therefore not worsened. However, it is coded as a new pressure ulcer because it was not present on the sock rock. So it was put in here a little confusing. So we had it, it became covered with eschar, we debrided it, it stayed at the same stage, but because it wasn't present at the start of care, it's considered, again, that word new or worsened. So the quality measure for pressure ulcers that are new or worsened has multiple covariants for risk adjustments, and they're written here, and you're going to learn all about those tomorrow. It's important to understand that M1313 is used in the calculation of the QM. So 1311, all the work we did on that was just to establish what was there at the start of care. So it's important because it's a comparison measure, but it's the answers that are at 1313 that are used to calculate the QM. Some of the C2 changes that happen, Roman numerals replace the Arabic numbers. Each M1311 response now has 2 parts, and 2 additional unstageable categories were added, and we went through that. There, very quickly, I talked about the action plan, so you may want to think about it today and certainly use it tomorrow. What are the things that you want to think about when you go back to your agencies? Some of the questions that came up to me during the break were, are the actual answers to the scenarios and the rationale going to be made available? Yes, that will all be made available so you can use it for training. So you may want to take it and tweak it a little bit, change it, but at least you have the methodology there and you can use one of your own patients. Certainly that makes it more relatable, usually to your staff. And then review your current way you are documenting pressure ulcers and all OASIS time points, and review and update your tracking process to include the 3 unstageable pressure ulcer categories, and then practice a variety of scenarios with your staff. That's the biggest thing. We did a lot of practice here. I think that's just the best way to do it, and have discussions and talk it through so that staff really, you understand by the time they walk away from some of your trainings, they really understand how they're supposed to be coding. And then there's a variety of resources that are made available to you.